Speaker today. We are blessed to be able to continue to expand our speaker pool. And today we have Dr. Jasmine Cutler. She is originally from Odessa, Florida, not Tampa, but specifically Odessa. She got her PharmD from the Florida Agricultural and Mechanical University in Tallahassee, Florida in 2007. She obtained her consultant pharmacist license later, and she's also certified to administer immunizations. She started off as a community pharmacist, and then she pursued a 2-year interdisciplinary women's health fellowship at the University of South Florida. During her fellowship, she performed various duties at Bird's Alzheimer's Institute, assisting with interdisciplinary care clinics and medication reconciliation, as well as medication education. In addition, she obtained a women's health graduate certification, a USF pharmacy graduate teaching certificate, an excellence in pharmacy education certificate, and a certification to be an HIV/AIDS counselor. Upon completing her fellowship, she was appointed assistant professor with the concentration in geriatrics at the University of South Florida College of Pharmacy in Tampa, Florida, under the leadership of Dr. Kevin Sneed. At the college, she's performed several clinical duties at the Neuroscience Institute, a local assisted living facility, and Reliance Medical Center. Dr. Cutler equally enjoys participating in community events, mentoring, and using her expertise to educate the community. While not at work, she loves to spend time with her family, travel, exercise, specifically playing volleyball, dancing, watching movies, and attending concerts, as well as church activities. And with that, even though she probably makes me as a speaker look bad with an excellent intro, I give the floor to Dr. Cutler. Thank you very much for joining us today, Dr. Cutler.
Thank you for having me, and thank you for giving me this opportunity to speak today. As he already mentioned, the Senior Care Education Conference is coming up, so be sure to go ahead and use this link to register. If you have any questions, you can definitely ask or email Miss Lisa Stearns. I know I will be there. I'll see you there as well. So without further ado, we'll go ahead and get started with today's presentation. So today I will be talking about glaucoma, the past, present, and the future. So today I'm going to give you an introduction on glaucoma. We're going to talk about epidemiology as well as etiology. We're going to go over pathophysiology as well as review risk factors. We're going to talk about the signs and symptoms associated with glaucoma. We're going to spend most of our time, of course, as pharmacists, talking about current treatments, old treatments, as well as new treatments. And we're going to finish up talking about a couple counseling points that we want to always remember for patients whenever we're dispensing this in a retail setting, or if we're even seeing some of these patients who are getting discharged from hospitals maybe, or even in some of our other care opportunities within ambulatory care or some of those other facets of pharmacy. So let's do a quick review as we unveil the curtain. So what exactly is glaucoma? Glaucoma, again, is a disease of the eye caused by damage to the optic nerve, and it leads to the visual field loss as well as visual sensitivity. Of course, glaucoma has two separate portions. There's POAG, which is the most common type, which is the primary open angle glaucoma. It's of the most cases in the United States are of the open angle, and those are the ones that we generally use, a lot of the treatments that we have available. The other type is the primary closed angle glaucoma. That's actually more prevalent in the Asian population. And with all of these, you see an increase in intraocular pressure, and that's thought to play an important role in the pathophysiology of glaucoma, but it's actually not a diagnostic criteria. We'll talk about that a little bit later. Consistently elevated intraocular pressure without signs and symptoms of glaucoma is called ocular hypertension, although we use some of the same treatment options. So when we look at this next slide, this kind of shows the visual field differences. So as you can see on the left, that's the normal vision. As you can see, everyone can see the periphery. And on the right, you can see what occurs when patients end up with glaucoma. Up highlight is the increase in intraocular pressure, which I'm not sure if my mouse is actually active, but if you see here the purple portion, you have an increase in the intraocular pressure, and that's going to directly be due to the aqueous humor. So the aqueous humor is not able to drain, and because of that, it's going to increase the pressure, and with increasing the pressure, it's going to damage the optic nerve over time. So let's talk a little bit about epidemiology. Again, it's the leading cause of irreversible vision loss worldwide. In the United States, we have over, at this point, 4 million individuals with glaucoma, and it can end up leading to blindness. The issue is that it's largely asymptomatic, especially in patients with open angle glaucoma. It's actually sometimes called the silent killer because of the fact that it progresses slowly over time. And sometimes patients they're not even aware that this pressure is building up until until it's very severe. So as you can see, only 10 to 50% of individuals are even aware. So the remainder are unaware that they even have glaucoma or that this pressure is building up. So because of that, it costs up to $2.886 billion every year in direct and indirect costs. And that's due to loss in productivity, as well as in those in which the disease ends up causing blindness. So let's go ahead and compare the two between primary open angle glaucoma, which is the one that's most common, and the closed angle. So the primary open angle glaucoma is characterized by increased resistance to drainage, while the drainage angle is actually open. So there's going to be a picture coming up on the next slide that kind of goes into a little bit, and I'll go into a little bit more detail. So because it's unable to drain, this blockage causes an increase in intraocular pressure. And again, that's going to end up resulting in optic nerve damage. And the loss of vision is very, very gradual over time. And a lot of times it can be asymptomatic. And because of that, patients are unaware and they may not seek treatment earlier. So the main goal in order to prevent and to treat this is to lower this intraocular pressure. The other type of glaucoma, which is a closed angle, is usually due to an obstruction, and it's usually due to a disorder, maybe at the iris or the lens. So it's actually more of a structural issue in which it causes, in most cases, the lens and the iris to actually touch. And because of that, it's going to block the angle and not allow any of that aqueous humor to actually drain at all. In this case, a lot of patients will have more acute symptoms. So a lot of times patients are actually able to notice this type of glaucoma. And because of that, it generally causes or leads to an emergent situation in which patients may need to see a physician quicker or optometrist quicker in order to get that resolved. And generally it's resolved via surgery. So it causes a resistance, again, in the aqueous humor. So the increase in intraocular pressure is going to be very, very, very quick, and it can end up causing blindness in a matter of a few hours to days if it is not actually treated. So this picture kind of shows more of the angle. So as you can see on the left side, there's an open angle. So everything is able to drain the aqueous humor. So what occurs is that you end up with a build up of the aqueous humor within open angle glaucoma, as opposed to closed angle, in which this trabecular meshwork is actually completely unable to drain because of the fact that this angle is closed. So as you can see, the one on the right is more of an emergent situation, whereas the one on the left is gradual, and that is the one in which we usually use various treatments to assist with relieving. So I wanted to go into a little bit more detail on the pathophysiology. I kind of discussed the optic nerve and the damage that can occur. And again, the open angle is going to be slow and progressive. It can change the intraocular pressure, and it's influenced sometimes by pulse, blood pressure, even coughing. We're going to talk a little bit later about some of the lifestyle choices or things we can recommend to patients with decreasing smoking. Of course, we can't do anything about decreasing age, which is something that we can take into account as being a risk factor for glaucoma. But again, it is not something that stands alone. So with that, you have the optic disc, which is made up of 1 million of the retinal, over a million of the retinal ganglioid nerve endings or the axons. And what happens is that supports that connective tissue that I showed you in the previous slide. And when these axons die, the cup or the optic disc cup actually becomes bigger. And as it becomes bigger, it leads to the visual field loss that you will see with glaucoma, and that can lead to the permanent vision loss. Again, with the closed angle, you'll have that quick, high increase in the IOP because it is a complete closure. And a lot of times people's IOP will even go up to 40, and that's going to cause the optic nerve damage. And if it gets above 60, it can cause that permanent damage that I spoke about that can occur within hours and potentially days. So these are some of the key terminology. Previously, I spoke about ocular hypertension, which can occur with elevated interocular pressure, and that is usually resolved through treatments that I will talk about soon. But you have no signs of the optic nerve damage or the visual field loss. Now, with normal pressure glaucoma, you can actually have normal intraocular pressure, which I mentioned, and still have that optic nerve damage. So because of that, intraocular pressure is not the sole diagnostic criteria that we use when actually diagnosing a patient with glaucoma. And again, we have the normal glaucoma where everything is elevated, and we have the optic nerve damage that occurs. So let's talk a little bit about risk factors. So I mentioned age. So anybody over the age of 65 is at a higher risk. You have a higher risk if you have an increased cup to disc ratio. I kind of mentioned that with the death of some of those axons, it causes that cup to get larger and the ratio to increase, and that puts people at higher risk for glaucoma. So if you have a reduced corneal thickness, so patients who actually have a thinner cornea are at higher risk. Again, the pressure, if it's above 22, that's going to be a general sign. Generally, most patients, the normal intraocular pressure is anything below 20. So that's for normal individuals. And when it starts progressing, it puts them at higher risk for glaucoma. Family history. So those who have a family history, I know myself, I always go get my eyes checked very, very often, only because I have at least about 10 individuals in my family, mostly a lot of my aunts who actually have glaucoma, so it puts me at a higher risk. African or Hispanic ethnicity places people at 4 times the risk for having glaucoma, as well as type 2 diabetes. If patients are actually nearsightedness, which is why I have these glasses on now, that puts you at a higher risk, as well as the use of systemic corticosteroids. So on the next slide, I have a list of some of the drug-induced glaucoma as relates to which type. So with open angle, it's a list here on the left of which systemic corticosteroids are on there as well. There is a little highlighted star saying that some of these are at lower risk than others. So again, this you have to take with a grain of salt and also place along with some of the other risk factors that patients already have that will put them at higher risk. All right. And for the next slide here. So again, with the clinical presentation, I mentioned that normal intraocular pressure is generally anything less than about 20. Generally, most patients are between 10 and 20, 21. It becomes considered abnormal once they get over 21. And then whenever you see a patient generally in the 40 range, that's usually due to the primary closed angle glaucoma, which again is more of an emergent situation. As I mentioned, it's kind of that silent thief of the night. And as you can see, early glaucoma, it only kind of affects the periphery slowly. And then once you get to the extreme, there's no way to actually see in the periphery. And patients only kind of see, like, I guess you can say, a little spotlight or kind of like a little piece. As far as closed angle glaucoma, it's characterized by attacks. So you have severe pain in the eye, redness. You get the halo vision, headache. People start sweating. So with any of that, it's going to be emergent. So detection and diagnosis involves actual evaluation of the optic disc as well as the nerve fibers and assessment of the visual field. So those are the things that are used to actually diagnose glaucoma. They do measure the intraocular pressure to see if there's an increase in intraocular pressure, although again, that is not going to be the self or the one single use for diagnosing glaucoma. All right, Miss Lisa Stearns, if you would like to bring up our first polling question to see how many people are listening and engaged today. All right, if everyone can read it, it's normal angle glaucoma or narrow angle glaucoma is characterized by a decrease in drainage of the aqueous humor, death of the ganglial cells, and a slow progression of the disease, and generally asymptomatic. Do we have true or false? All right, I'll give you a couple more moments. All right, can we go ahead and see how everyone did on the first polling question? All right, perfect, perfect. So for the first polling question, the actual correct answer is false. So it is false generally because it is not a slow progression of the disease with narrow angle or closed angle glaucoma is generally immediate and it is symptoms related. And it's again, it is due to a drainage, decrease in the drainage, but it's generally due because of the fact that it's structural, generally with that iris and the cornea or the lens actually sticking to each other. So it's going to be very, very quick. And generally it is symptomatic as opposed to the open angle, which is not. All right, well, thank you guys for your responses. So let's switch over to therapy goals. So what exactly do we do? So again, we're going to want to relieve the acute symptoms for patient comfort. And in closed angle glaucoma, that's generally going to be potentially a surgery. For those with open angle, our main goal is to lower the intraocular pressure. So again, if patients are above that 21 mark, we want to try to bring them down to kind of preserve the nerve. So with that, the initial target is a 20 to 30% reduction below baseline. So wherever they started, we want to reduce it slowly, about 20 to 30%. We want to also prevent any additional damage because as you can see in the previous slide, we saw the normal vision and early glaucoma. We definitely don't want to see them progress to that extreme glaucoma stage. So we want to slow down that progression to that pinpoint site. All right. So as far as therapy options, mostly everything that we have will reduce intraocular pressure, and that's going to be our general go-to, again, for the 20 to 30%. So you can also use non-pharmacologic interventions, which I'll talk about, and you use those alone or in combination. In general, most patients end up needing 1, 2, even sometimes 3 therapy options that can be combined together. And we will have to look at the side effects, the cost. Cost is going to be a huge issue with most patients, as in most of these newer agents are actually not generally covered, or they can be very expensive for patients. They can be in tier 3, they can need a prior authorization. And this is going to be important because these eye drops, some of them need to be actually instilled several times a day. And that's going to create an issue for patients, especially maybe if they are older and they may also have like arthritis or other issues with actually being able to instill those drops. So we do have some things we can recommend. I'm not even sure if I place it in this presentation, but there are a few devices that are available at a lot of local independent as well as corporate pharmacies in which you can place the actual eye drop into a device and use it to help instill those drops, especially for those patients who may have arthritis or inability to kind of put in those eye drops. A lot of other things to think about with adherence is several of the eye drops have to be instilled several times a day. And that can create a problem. Patients who are on multiple medications, so they almost have to even set a timer to remember when they should take their medications, especially even an eye drop. So the degree of pressure lowering and even comorbidities is something to think about as well. So if one medication does not work, sometimes you have to switch to another or even add in additional medications. So some of the non-pharmacologic treatment options helps to reduce or relax the surrounding nerves would be the eye massage. You also have palming, which is applying pressure on the eye to relax the muscle and induce circulation. And then they have a figure eight in which you kind of do around your eye, and that increase the flexibility of the eyes and relax the eye muscles. So those are some things we can do. We also may want to check and see if patients are on any of those medications that can increase the intraocular pressure, because if so, we may want to consider giving them an alternative medication. I mentioned that with the closed angle or the narrow angle glaucoma, more often you may need laser or surgical treatments in order to allow that aqueous humor to drain. So these are the various surgical procedures used. And as you can see, the last one is a treatment of choice, especially for the closed angle. And it actually produces a hole in the iris again to allow the direct flow of the aqueous humor from that posterior chamber to the anterior chamber to relieve a lot of that pressure. So there is again always algorithms of what to do with patients pharmacologically for patients who have glaucoma. So these are some of the treatment options that are most seen. We have the prostaglandins, the beta adrenergic blockers, the alpha adrenergic agonists, carbonic anhydrase inhibitors, the parasympathomimetics, which are also cholinergic agents, as well as the newer ROCK inhibitors, which came out a couple years ago. And there's actually been two medications after that that I'll talk about as well that are on the horizon. But even with all these various options that are available, the prostaglandins are generally the still start and go to with most patients with the open angle glaucoma. So we'll, as pharmacists, we'll look back at what are the various mechanisms of action for each of these. So I talked about the buildup of aqueous humor. So generally, all of them are going to be generally highlighted, or their main goal is to decrease that pressure that we see by allowing that drainage in the end of the aqueous humor. So the prostaglandin analogs, they're going to lower it by again increasing that outflow. The thing to know about these is that they're thought to result in remodeling actually of the extracellular matrix in that meshwork that I showed you in the picture, and that's going to allow for the aqueous humor to drain, as well as the alpha adrenergic agonists. Those also are going to be seen or to help with that remodeling. So those two work kind of hand in hand, which is also why it's important, or in some patients, that they may need to be on multiple drops. Generally, again, they're on drops from different mechanism of action to increase effectiveness of the intraocular lowering or intraocular pressure lowering. The prostaglandins, the one huge thing is that they only have to be administered once daily. So that's really good with increasing adherence. Several of them are now generic, so they're available for patients, and they're usually cost effective. The max effect can be reached within 8 to 12 hours. Now, when we look at the beta adrenergic blockers, they're going to again reduce that aqueous inflow with the blockade with that ciliary body that I showed you from the picture earlier. The disadvantage of these is that they have to be administered more than once a day, and they're contraindicated in patients with asthma, COPD, bradycardia, CHF, and they have a lower response. It may take a couple weeks. It may take up to 4 weeks for them to actually start working. Now, the alpha adrenergic agonists, they're going to reduce that IOP again by decreasing the rate of aqueous humor actual production. So they work in the other way of decreasing the production. The disadvantage is it has to be administered 3 times daily in most cases. So a lot of times adherence becomes a huge issue with these particular patients. The other two kids on the block are the carbonic anhydrase inhibitors. So they're going to inhibit aqueous production through the blockade of an active secretion of the sodium bicarbonate ions from those ciliary bodies. And that's going to reduce the intraocular pressure. Again, an issue that we see is adherence. You have to administer these 2 to 3 times a day. And you do not want to combine any oral and topical carbonic anhydrase inhibitors. So adding or putting them together is not a good sign for at least these two medications. Now the cholinergic agents, which also you don't see used that often, they include that old school pilocarpine that we used to always see a long time ago. It's going to appear to increase the outflow by physically opening that meshwork pore secondary to the ciliary muscle contraction, and that's going to allow the aqueous humor to come out. Again, the issue with these is that you have to administer them 2 up to 4 times a day, which can definitely be an issue for some patients, as I mentioned before. This was created from a while back here with I think Dr. Olbringer as well, a comparison of some of the treatment options and the cost. As you can see, the cost of the prostaglandin analogs are a little bit elevated, as you can see in here with $200, but a lot of them are now generic, so that's going to be very beneficial to patients. The few little highlights and pros I wanted to mention as I go through each of these boxes here is that the prostaglandin analogs, which interestingly have side effects that some patients actually like. I know, for example, it can cause the eyelashes to actually grow a lot longer. And the Lumigan itself has been marketed as Latisse to actually cause longer eyelashes. So that's one drug in which we have a side effect that people actually usually like, preferred to some of the others. Patients with light color irises, it can actually cause a darkening or a change in the iris color, and sometimes that will actually not be reversible with the use of the prostaglandin analogs. It can cause some redness in the eye, and if patients do have contact lenses, they want to remove them before actually instilling the eye drop, and it can be reinserted 15 minutes after administration of the drop. And generally, this is something that we see with all eye drops, so we always generally want to let patients know they need to remove those contact lenses, place the eye drops, and then wait about 15 minutes before putting those contacts back in. But again, since the prostaglandin analogs are generally administered at night, we know most patients are not supposed to be sleeping with contacts. So at least you can take your contacts out and then go ahead and instill those drops. The advantage of the prostaglandin analogs, as you can see, is it has the greatest reduction in IOP, 25 to 33%, which is the reason why those are still our go-to agents in most patients with the open angle glaucoma. All right. And if I move on to the alpha 2 adrenergic agonist, those can cause some dizziness and fatigue. And as you can see, the reduction in IOP is a little bit less compared to some of the other agents. So that's why that one is secondary or not as preferred as some of the prostaglandin analogs. When we go to the cholinergic agonists that I kind of spoke about earlier, they can also cause a reduction about 20 to 25%. Again, we see the pilocarpine there, and we see some of these side effects, which are a little bit more side effects compared to some of the prostaglandin and the alpha-2 adrenergic agonist, which is why patients generally, we don't see those used as much, the cholinergic agonists. There are also, oh, my apologies, there are also combination products such as Combigan, and sometimes that can be cost effective because it's going to end up combining 2 medications in one, and that's going to help reduce the intraocular pressure and also reduce the amount of various eye drops that patients actually need to instill. Then we look at the carbonic anhydrase inhibitors that I spoke about a little bit earlier. Those are associated with a little bit more side effects, and that one does have an oral version of Diamox. But again, you cannot combine the oral with the topical together. You can see the reduction in IOP is a lot less, only 15 to 20%. And with the particular, let me see which one is it, with ASOPT or brinzolamide, you actually have less burning or stinging of the eye because the pH is more closely resembles the pH of the tears. So as far as this class, I would probably lean more toward recommending ASOPT if patients have side effects due to carbonic anhydrase inhibitors. Things to keep in mind is whether these products have preservatives. It's going to be important to know if the product has preservatives or not. A lot of patients become more sensitive to preservatives and they would like preservative-free products. And with those, again, we know that they do not last as long, and we have to be very careful of expiration dates. Another thing to note that I don't think I mentioned in the previous slides, a lot of the prostaglandin inhibitors have to be refrigerated. So we have to be aware of storage of them, especially within the pharmacy, before we actually dispense them to the patient, and how long they can be out of the refrigerator before they are not good anymore, or at least will not provide as much of an effect or therapeutic effect long term with due to the expiration of the product. We have the beta blocker agents that I kind of mentioned before. They're again contraindicated in patients with asthma, COPD, bradycardia, and CHF or congestive heart failure. Again, the reduction is a little bit lower compared to the prostaglandins and some of the other agents on the previous screen. Another thing to note is that they have minimal effects on nocturnal IOP. So the prostaglandin inhibitors, they're generally, again, the ones from the previous page, the prostaglandin inhibitor or not inhibitor, the prostaglandin analogs are generally administered at night. And that's because they can cause some of that blurred vision, and also because they actually end up reducing the intraocular pressure really, really well at nighttime, in which we see for some reason an increase in intraocular pressure, although we don't really know the mechanism behind that. So when we talk about again, these beta blockers, they have minimal effect on the nocturnal increase that we see in the IOP. And because of that, they're not as used as often. And because of the fact that their effectiveness or the amount of time that they take effect are very, very short, you have to end up instilling them more often. Now, we do have one that is selective, the betaxolol, which is on the bottom of this chart here under beta blockers. And that's actually beta 1 selective. So because of that, it has less side effects compared to the other beta blocking agents. But the disadvantage is because it is more selective, it's actually less efficacious and generally does not reduce IOP as much compared to some of the other products. So those are things that we always want to keep into or take into account. With the beta blocking agents, they may require a few weeks to actually stabilize and see an effect. So follow-up generally is about 4 weeks later. And then I also mentioned some of the combination products that are available. So before we get into the latest therapies, Ms. Vanna White, can you pull up our next polling question? All right, everyone. So this is a question about mechanism of action. So which glaucoma treatment modality reduces IOP by inhibiting the aqueous production through the blockade of active secretion of sodium bicarb ions from the ciliary body? All right, we'll take a few more moments. All right, what is our verdict? Perfect. So thank you, everyone. It is a carbonic anhydrase inhibitor. So those are going to affect the sodium bicarbonate ions specifically. And again, those are not used as often, generally because of the fact that they only lower intraocular pressure about 15 to 20%. So let's look at some of the latest therapies that are available. As you can see, this starts with the word latanoprost, which is very similar again to a prostaglandin analog. So with this new therapy, it's metabolized actually into two various moieties, and they target the meshwork as well as the pathway. As you can see, compared to Xylantin or latanoprost, which is a prostaglandin analog, this new product actually ends up lowering the intraocular pressure a lot more. And so that would be one of its huge benefits. Again, as we know, whenever we get a new medication, the price of that medication is usually expensive for patients. One advantage again of this product is that it's tried and true because it's very similar to the prostaglandin. It works actually in two separate ways. And again, it's going to only be administered in the evening. So that's going to be very helpful for patients for adherence purposes. All right, as I mentioned, the cost is going to be something to take into account. And as you can see, the cost can be about $360 and upwards for the 5 ml bottle. And a lot of times insurance may or may not cover this product. It's going to cause some of the same side effects that I talked about with the prostaglandin analogs, or the ones that were actually on that first slide. So you may have some side pain, eye irritation, and even some redness. But as you can see, the percentage of this is going to be a lot lower. You will have those eyelash changes as well, which again, sometimes people actually like and prefer in some cases. So let's look at one of the other newer agents, and this newer agent is going to be Ropressor. Ropressor actually is considered a ROCK inhibitor. I mentioned a ROCK inhibitor earlier in the presentation. So it has a novel mechanism. It's believed to reduce intraocular pressure by actually increasing the outflow of the aqueous humor, again through the meshwork, but it's going to do this through a different mechanism compared to the prostaglandin analogs that we have. The only thing that we know, again, is that this medication is pretty expensive, and it actually has not been proven to be more beneficial in reducing intraocular pressure with these new mechanisms compared to timolol or latanoprost, which we already have on the market. The one advantage is, again, it can only has to be instilled once a day in the evening. So that's one advantage. As you can see, the adverse effects, it causes a lot of redness and sight pain, especially more compared to some of the other products that are already on the market, and even the product I just spoke about. The cost is a little bit lower, I guess, compared to the last medication I just spoke about, because it is once a day, but the cost is about $109. And generally, a lot of insurance will not cover it because they will cover the prostaglandin analogs. And usually patients will have to fail therapies in order to have this medication covered. And again, that eye redness and the side pain can be a lot for patients. So the recently approved FDA medication, the last one on the market, is called Amlati, and it's the first of its class. So it's a relatively selective prostaglandin. So it's very selective, and it's indicated both for open angle as well as ocular hypertension, which I spoke about earlier. It's again dosed only once in the evening, and it's good for patients who can't tolerate maybe latanoprost or some of the other prostaglandins that are already on the market, because it is again selective. So the increases the intraocular pressure lowering effects in combination with temolol. So you may see this product later on being one of those combination products. Because it's newly approved, it's actually not even yet available. I tried to look before this webinar, but it's actually not currently available to order. Some on this call may be aware or been able to maybe order this, but I have not seen it actually available yet. And it's already available in Asia and Europe, and it's made its way over here to the United States. And it received approval about now, I guess you can say, a little bit about like a year and a half ago. All right, so if you would like to go ahead and set up our next polling question, Ms. Stearns. So this next polling question kind of looks at counseling points. I'll be talking about those toward the end of this presentation, but I just want to see how the audience feels or what they think. Right, Miss Lisa, if a couple or enough individuals have responded, we can go ahead and see what everyone thinks. All right, perfect. So mostly everyone got this. It can cause an increased growth in those eyelashes, which for me would be a good thing. And you can see pigmentation changes. The reason why we generally do not end up increasing it to twice daily is that it actually has been shown to be less effective if you increase installation of the prostaglandin analogs more than once a day. Generally, we want to instill it at nighttime. Again, it will help with the nocturnal increase in intraocular pressure, as well as it causes some blurry vision. So we always like to instill it at night. And some formulations actually do not contain preservatives. The particular formulation, or Zyoptin, is the brand name. It's the only one that is actually preservative free, and it actually comes in unit dose vials. So that's something to note if patients really have issue with preservatives. There is a prostaglandin analog available for them. All right, thank you for this poll. We'll go ahead and continue the presentation. Also, Mr. Michael, has anyone had any questions in the chat as I've been going? Just want to make sure. All right.
I think we are good, Jasmine. So any others that may come in between now and then, we can answer at the end. But also just make sure everybody is aware if they have any questions throughout the presentation to type those into the Q&A.
Oh, yes, thank you. My apologies. If anyone has questions throughout, please be sure to type those in. And I also have my email address at the end. So if we have any questions in general after, you can definitely email me, and I would love to get back with you at any time. All right, so let's look at these treatment approaches. Let me go back. So what do we need to do initially? So the first treatment options, as I kind of mentioned before, would be a prostaglandin analog and generally a beta blocker, because they're going to cause a lot of that lowering of that IOP. An alternative would be something like brimonidine. If a contraindication to first-line treatments occur, you can consider going to that carbonic anhydrase inhibitor. So we generally want to assess after 2 to 4 weeks. Again, with a beta blocker, it may take up to 4 weeks more so to see some of the effects. And if the intraocular pressure has not been at goal, which is at 20 to 30%, then we may want to either change and use a different medication, or we may need to add in a medication. During this time, it's important to ask patients, are you actually using these every single day? Are you also using that nasolacrimal occlusion technique in which you put your finger over kind of the area here in your eye, right here when you're instilling it, to make sure that it's not absorbed systemically? And again, if there's no response, you want to switch, or you may have to add in another agent. So if you don't get any type of response or decrease in intraocular pressure, you want to make sure that you're normally seeing the patient and doing follow-ups and assessing every 2 to 4 weeks. So again, we're going to be doing the same thing if it's still an inadequate response. And then after that, you might want to consider adding in that anticholinergic agent if necessary, or you want to consider maybe an oral. But again, if you do an oral, you will have to take away the topical carbonic anhydrase inhibitors, because you cannot use both at the same time. And again, you may have a patient on multiple drops. If it becomes even more of an issue, intolerance, or we're having issues getting that intraocular pressure, again, laser or surgical procedures may be in order. In patients, again, with the closed angle glaucoma, we may have to go to surgery a lot sooner, because again, it's going to be due to more of obstruction due to an anatomical issue versus actually due to the aqueous humor just causing that increase in intraocular pressure. So for intolerance at any stage, you want to reduce the dose or concentration of the product if patients are having redness, if they're having stinging, if they're having some of those side effects I mentioned. Changing the formulations, again, there's preservative free as well. Switching to an alternative class. So if patients are having a lot of issues with one drop, we have a lot of other choices, even though they may not decrease intraocular pressure as much. Or we may want to even switch to an alternative combination products, of which I kind of mentioned before. Some of the important patient education tips to improve adherence is to make sure we let patients know that they have devices available and things available for patients who may have difficulty with actually instilling those drops. I kind of mentioned that before. And then make sure you maybe tell them things such as where to store their eye drop near a certain area, either maybe near their dresser at night or something like that. Also, having patients actually put timers on their phone or clocks or use those type of things to be a good reminder that they might need to instill their eye drop. Always washing your hands before administration, because we definitely do not want any kind of contamination. Shaking the bottle if it is a suspension, creating that pocket as it shows here with the lower lid, and making sure you're tilting your head upwards. So as you're putting in the drop, there's a lot of various information online and different type of sheets or printable sheets for patient education on how to actually instill eye drops correctly, and making sure to close the lid for at least 5 minutes after installation. As I mentioned before, you want to remove those contact lenses at least about and leave them out for about 15 minutes. Patients have multiple eye drops. As I say, the order of eye drops is very important. So you will want, if they have a suspension, a solution, even some eye drops come as more of a thicker ointment, you also want to put the solution in first, the suspension in second, and then the ointment. And the reason for that is that if we apply the ointment initially, a lot of times the solution actually will not be able to penetrate the eye in order to even be useful. So you always want to go with the thinnest, as I say, up through the thickest whenever we're using multiple eye drops. And in generally, if you're using multiple eye drops, this is a good slide that kind of talks about how to space them out. So beta blockers, you want to space about 10 minutes apart from other drops, prostaglandin analogs, and alpha agonists, as well as all the rest, about 5 minutes apart. A lot of times patients, I find they just put the eye drops in quickly right back to each other because they want to kind of get it over with. But it's important to allow each one to penetrate in order to help it be more efficacious. It's also easy to identify caps. So this was something lovely that was placed here, or that was included about the bottle top colors. So some of the colors actually are going to be related to the mechanism of the eye drop, in case patients have multiple eye drops and they can't remember if they put in one versus putting in the other. So that's going to be very helpful for a lot of our patients. So as we conclude here, I'm going to be having Ms. Lisa pull up the last polling question for today. It's going to be a 3-part question, and it's related to a case. So we have AF. He's going to be 66-year-old white male, and he's recently diagnosed with, again, open angle glaucoma. He has a past medical history of type 2 diabetes, asthma, as well as hypertension, and he has high triglycerides. His current medications include metformin. He takes that 500 milligrams twice a day. He has losartan for his blood pressure, 100 milligrams a day. Rosuvastatin, 20 milligrams nightly, because we know we got to combine that, especially in diabetic patients. And montelukast, 10 milligram nightly, as well as he's on a couple inhalers or one inhaler rather, for his asthma, and he takes that Centrum Silver every day. So now that we know his history, we'll start with the first question. Which of the following would be preferred as initial therapy initially to treat his open angle glaucoma? And I believe these will all come out as one answer. So if you want to scroll down, questions 2 and 3 are there as well. If everyone can see it, it all goes with the same case. So the first question is about initial therapy. The second question is about risk factors that AF specifically has. And the last one is, once we start a therapy, what exactly is our targeted percentage of IOP reduction that we're looking for with patients? So I'll give you guys a couple minutes to look through this case. Right? I'm not sure if Miss Stearns, aka Miss Vanna White, would like to bring out our answers. If we have enough individuals, if not, we can wait a couple more minutes. All right, so it looks like mostly everyone got the first one. So latanoprost will be a good starting medication for this particular patient. I see a lot of people also went with the combination therapy, and a combination product is not usually considered initial therapy. Generally, if patient has to be reassessed, and if in 4 weeks we don't see any benefit, then going to a combination therapy is something that may be beneficial. Another thing to note is that this patient has asthma as well. So we want to kind of stray away from those beta blockers in those particular patients. Pilocarpine is an older agent. It's kind of fallen off from use. As the ROC inhibitor, I see a couple people selected the ROC inhibitor. It's more of a newer product and it's considered adjunctive. As I mentioned before, it causes a lot of redness and is very, very expensive. So initially, we still want to start with a prostaglandin analog, of which latanoprost is the best go-to for that. So let's look at our second question. This one was a tricky question. So as you guys mentioned, type 2 diabetes, family history, and Hispanic ethnicity are all definitely associated or risk factors of glaucoma. But I asked specifically which risk factors does AF have. So he actually only has type 2 diabetes. He is a white male, so that means he's not Hispanic. So because of that, he's not at higher risk, and it's no mention of family history. But if he was Hispanic or African American and had a family history, that would be risk factor. Asthma and hypertension are not really mentioned as possible risk factors, even though we do see a lot of people with ocular hypertension, which is usually not per se directly linked to regular hypertension, as I call it. The last question was about the targeted percentages of IOP reduction from baseline. So generally what we do is we want to see a reduction in 20 to 30%. So that's our overall goal. If we have not reached that, we may want to consider alternative therapies, adding therapies when we reassess patients at that 4-week mark, and then again, maybe at another 4-week mark. So it's important, and again, to look at how much each of those agents I discussed will reduce the intraocular pressure. And again, the prostaglandins are usually the go-to because they do reduce it really the most. And again, this is going to be compared to baseline. So wherever they start, we just want to see a reduction of about 20 to 30% for that particular patient. Well, thank you, Ms. Elisa, for that last polling. And thank you guys all for being attentive and participating. I really, really appreciate it. So in conclusion, glaucoma is the #1 leading cause of that irreversible vision loss globally. Again, there's not a cure, but progression can be slowed through those pharmacologic interventions. There are some non-pharmacologic that I mentioned, the eye massage, the finger aids, some of that palming that can kind of help as well as relaxing some of those muscles. But again, medication adherence is going to be key. So it's important to make sure patients are able to instill those eye drops that they need, that they're able to do it the amount of times they need per day. And that cost is also not a hindrance, as well as any of those side effects that may be actually coming along with any burning, stinging. And it's also important for us to properly educate them if they're using multiple drops to make sure that they're waiting the proper time in between, that they're instilling them in the correct order, which is going to be very important, and that they're removing those contacts as well. And again, that they're washing their hands before they're instilling them and using that nasolacrimal technique to decrease the amount of systemic absorption, especially if they're using these beta blockers and they may have some underlying medical conditions. So With that, if anyone has any questions, this last 4 or 5 minutes or so, I will be able to take questions. Thank you guys all for being attentive. I hope this was helpful, and thank you all for joining in on this poll. It was very, very good, and hopefully it ended up adding to or you learned about some newer therapies that are available and kind of highlighted some of the things that you already knew. And I'll end with my information. I think I didn't put it in here. I thought I did, but it is jcutler@usf.edu if anyone has any other questions after we do the Q&A session. Thank you so much.
Thank you very much, Dr. Cutler. We really enjoyed that. Great way to kick off the year. Plenty of thank yous in the chat. I don't see any questions at this point. Again, want to thank everybody for attending. For those of you, there was some interesting points Dr. Cutler made on some of the preservative-free medications and stuff. And I know as a consultant pharmacist, when we were in inspecting med carts and med storage and stuff, those preservative-free eye drops are often a target. They usually only last 4 to 6 weeks, generally around 6 weeks. So for those of you in long-term care facilities, you may want to keep an eye out on that. Is another little bit of a takeaway from a great presentation. For that, don't see any actual questions coming in, I don't think. Got a couple minutes. We're going to probably give everybody back on their day. And thank you again, Dr. Cutler. We look forward to having you back again. We may see Dr. Cutler later in the year. I already hit her up for another topic. So keep your eyes peeled, and hopefully later in the year we'll get her back. There's a question about how to get your continuing education. You'll get an email following the close of this presentation from Lisa with AME, and that'll give you the directions. So if you have any questions, you can always shoot an email to Lisa. And my answer was not recorded on the first question. Yes, you will be fine for CE. No worries. All right, everybody. Thank you very much. Appreciate your attendance today. And we will see you all probably in a month or less. So thanks a lot. Everybody have a great day. Thanks, Dr. Cutler.